Welcome back, OSLP family. Welcome. Oh my gosh.
Oh my gosh. We keep saying things and
I know. You are listening to Our Sleeve Life podcast, and this is Kelly.
And this is Mel.
And oh my God, you guys, what we have for you today
is insane.
It is absolutely insanity. We are mind blown.
I never thought we were going to have this opportunity.
No.
This is nuts.
And so you guys all know how much we adore Dr. Dovec. She is such a heartwarming person, and she just genuinely wants to help our community become bigger, break the stigma. And she's just, I have chills. I have chills.
I just love her because she's just all about it. All about us, and she's a hard fucking worker.
She is. She really is.
Seriously, she does surgeries back to back to back, man.
Yes.
It's insane.
And speaking of surgeries,
that's what
we're doing right now. We are about to hop on to the Zoom call with her, and we are going to watch her go into a live surgery.
Yeah.
Yes.
Can you think about that?
Yeah.
Holy shit.
Just hold that in your mind for a second and realize how mind-blowing this is.
Yeah, we're not doctors.
No.
We have no idea how any of this works, and we get to watch it and talk about it, and she's going to teach us things and tell us how it all works.
Yes.
Insane in the membrane.
I was wondering if you were going to say that.
Oh,
okay.
Yeah.
So we are going to hop onto the Zoom, and as soon as Dr. Dovec is in there, she will say hello to you all, and then we are going to describe exactly what we are seeing.
Yes. And I know that we're going to be in awe a little bit, so bear with us.
Bear with us as we watch this incredible surgery by this incredible surgeon.
Yeah. Wow.
I just can't even
it's just
comprehend.
I just can't believe that this is happening right now.
Yes.
I'm still in shock, guys.
And so you guys probably already know, we also are watching sleeve surgeries today.
Yeah.
And so it is very cool to watch a surgery and know that was done to you.
It's crazy thinking that oh yeah, that was inside me, that's what they were doing, there's puncture holes, this is insane. And Kelly's face right now wants to say that's what she said.
I want to so bad, but I did not. I held it in.
I love it. I
was trying to be professional, Mel.
That's okay. The doctors are not in the room yet. We can be us.
Yes. But we're always us. But we are, these surgeries are just life-changing, and we can't say that enough. And that's why we do this, is because we want to bring to the forefront of this society that this is a life-changing thing. It is not the easy way out. It is not a cheat. You're literally just getting a tool.
Your surgeon is choosing which tool that you get, the bypass or the sleeve, and sometimes a duodenal switch.
Yep.
And whatever's best. And it's not the easy way out because there's so much work that happens post-op.
Yes.
So much. Oh my God, I think we're about to go in, guys. I saw some things change.
So hopefully we're going in. So yeah, it is not the easy way out. And I think when people say that or that it's a cheat or they make assumptions about what has happened to us, I feel like it's because they are not informed of what actually happens.
Not at all.
They just see, they had surgery and now they're down 150 pounds.
Right.
They don't see the hard work that goes into it in between those 2 points.
No one ever fucking thinks of that. And that's what makes me mad. It's for anything to be successful, whether that's you losing weight, you having a your college degree, you having a successful relationship, it is work.
It is work.
And you don't get to see all of the work that's going into it.
Correct.
It takes years. That's why artists all the time, the grind is real. And people that play music, they don't actually get a recording studio to be backing them until they're 5-6 years later. So guys, same thing with us losing weight. It takes time.
It takes time. And it's a lot of hard freaking work.
Yeah, there's just so much work on the back end that people just don't see, and I don't think they appreciate that point. And that's why they think it's the easy way out, because they don't understand it.
Well, and here's my other thought. And I've been thinking about this a lot. Okay, so let me get my thought back. It just totally popped out of my head. I'm not even kidding you. Okay, so you continue to talk.
Yeah,
I will think about it.
I would say the other comment that drives me bonkers, especially like knowing that we're going to be watching a surgery, is the natural way. Okay, so Dr. Dovec did like, what, 8 to 10 years of schooling.
Mm-hmm.
And then she's been like, practicing for another like 8 to 10 years.
Mm-hmm.
What is unnatural about that? Like, she's a person, she's a human being, and she is literally taking her talents and giving us a tool. So how is that unnatural? Just because like something was punctured in my body? Well, guess what, buddy? You have fucking tattoos. Those are needles.
Mm-hmm.
What about all the piercings you have? Those are fucking needles.
Those
so
are unnatural.
why does it matter?
Mm-hmm. Yep.
I don't get it.
I mean, it's the same thing. So my thought is when people think bariatric surgery, what is the number one comment that you get, that you used to get?
What I used to get?
Mm-hmm.
Basically it was like, do you think you can keep it off?
That, and the fact that they would say, oh, well, I know so-and-so who got surgery, and they gained all the weight back.
Yep. It's always that one person that so-and-so and so-and-so knew.
So that's what people correlate with bariatric surgery.
Right.
They see, oh, they lost a bunch of weight and then they gained it all back.
Yeah.
So we need to stop talking about the negative.
Yes.
And just because people gain weight back doesn't mean that they failed.
No.
It doesn't mean that it didn't work. There are other mental things that are probably going on.
It has to be, because the surgery worked. The tool is there. It has to be used.
It has to be used. Correct.
Yeah, you have to use your tool. It's just like when you do a framing of a wall, you have to use the hammer, right? You have to have the nails.
Mm-hmm.
So if you don't use your tool right, the whole wall is going to collapse.
Correct.
So we need to drink our water. We have to have our protein. We have to have our vitamins. There's reasons why these surgeons say, hey, you need these things for you to be successful.
Correct.
So it's just like that wall. It's going to come right back down if you cannot use the proper tools.
Yes. Use your tool correctly.
Yeah.
Yes. So we are bringing all of these surgeries to the forefront of the society.
Yeah.
And I don't care who the fuck you are. I will tell you exactly. I have actually done it in like a 7-Eleven. It was a little market. And I had mentioned, I had weight loss surgery. And they said, oh, isn't that the bypass? And I was like, okay, let me educate you a little bit. So, okay, we are going in.
We're going in.
I think we're going in.
Yeah.
Let's see.
They're accepting all the stuff. This is crazy.
Let's get that going.
And by the way, guys, I'll say it to someone's face if they start saying easy way out, natural way. Yeah, and I will comment you on Facebook, Instagram. I don't give a fuck. Yeah. I will tell you like it is. You guys know me because I get angry about that stuff because we're trying to break that stigma.
Yes, that's our whole point. That is our whole mission during this process of doing this podcast, doing our Instagram, doing our YouTube page, all of those things. Our straight up mission is to break that goddamn stigma that we are failures.
Yeah, like we are the voice for our community and we are going to fight for this. Like we aren't going to be done until everybody on this goddamn planet gets over themselves and is totally chill about the fact that we want surgery. Okay. It's connecting.
Okay, we're going to join the audio.
Oh, here we go.
We're going to start the video.
Ooh, there we are. We can see us.
Hey, can you guys hear me?
Yes.
Hi, girls. Hi, Kellie and Mel.
Hey.
Hi.
I'm coming into the operating room. I just scrubbed in.
There she is.
Yes.
Look at her.
Hi, guys. Hello.
Yeah.
So what we're doing is I am getting into my gown, and we are getting gloves up. We're doing sterile techniques. So I scrubbed in, and now I'm ready for action. We're going to spin around, do a little dance, boop.
Yeah.
And we're ready to go. Here we go. We're going to be doing the sleeve.
All right, we're going to rock and roll.
With a timeout. All right, we're going to take a brief pause.
Okay.
Can you put it on mute for 1 second?
There we go.
Perfect.
Yeah.
Muted.
Yeah.
All right. we're good to go.
We're good to
So
go.
what we're going to do is we're going to get started with the sleeve here. I am going to put the first incision to get entry into the abdomen. I'm going to put it right here in the belly button. We want to keep this very, very cosmetic. And what I'm using is a local numbing agent to numb it up. And I'm using a very long needle there. It's called a spinal needle to really get that stuff in there to hopefully help her to have as little to no pain as possible.
Yes, that's what we want to
so
hear.
what I'm going to do, yes, for sure. All right, I'm going to identify all the layers of the abdominal wall. There's some fat, and I'm coming down. There's her fascia, and finally, her peritoneum here. Boop, and we're in.
Yes.
I'm inside the abdomen. Here we go. Watch it. It's going to blow up, guys. So I'm putting it on. I'm putting it in, and watch the abdomen blow up. Here we go. Here it comes.
There it goes.
Oh my gosh. I think that's almost my favorite part.
I know, right?
Just watching it.
The CO2 is just going.
Oh my gosh.
Crazy.
So
CO2 is going in.
yes.
And we are blown up. So now we have access to the inside of the abdomen. Welcome to the abdomen here. That is the liver.
Oh, look at that.
And here we go. So I'm going to put a little tiny incision on this side.
Okay.
It is going to be another 5 millimeter incision. So I use an 11 blade scalpel here.
And that's your
I'm gonna
favorite
just
blade,
cut-
right?
Oh yes, I love an 11 blade. Most surgeons like a 15 blade. If they do open surgeries, they like a 10 blade.
Okay.
But I like the 11 blade.
Awesome.
All right. Now I'm going to have my assistant. He's going to put another 5 millimeter trocar. And trocars are these instruments that allow us to go inside and outside of the abdomen. So we have the internal view of the abdomen here. We have these little trocars there, and we're just numbing it up. You saw the needle. So we know exactly we're in the right area that we want to be in, so that that's why we use the spinal needle to help us to be able to tell.
Okay.
Yes.
Okay.
Yeah, it gives you more room.
This right here,
Oh, look
do you
at
see
that.
these? That's small intestine.
Oh.
That small intestine I just showed you.
That is so crazy. Oh,
You
yeah.
see that yellow? What do you think that is?
That would be fat.
That's the fat.
right?
Yes, that's the
Okay.
fat. Yes, there's a fatty covering that covers all of our intestines, and it is called omentum. Do you see that? You see the abdominal wall and how
Yes.
there is a little bit of fat stuck to it right there?
Yeah.
Yeah.
That is, whenever you hear people talk about, quote, scar tissue,
Okay.
Mhm.
that's it. That just means that fat or intestines that aren't supposed to be are actually stuck to the abdominal wall. So I'm going to separate the two. So just stay in that position. I'm going to first take this,
I was gonna
and
ask.
I'm going to go in and I'm going to separate that little bit of fat
Okay.
from the abdominal wall there. Just take down that little adhesion here. Let me see if I can do this. This is mirror image.
That's
Let me try to do it for this one. Very, very close here.
It's just crazy
Alrighty.
seeing this, guys. So everybody from home, like, so we can see like the fat just hanging from the top of the abdomen.
Yeah, crazy.
And what Dr. Dovec is doing is that she's not suturing, but
Cauterizing,
cauterizing it off, or
cutting it off.
cutting it off.
Yeah, you guys are getting good with this. So this instrument that I'm using is a ultrasonic dissector, and that means that it vibrates very, very quickly to help to seal the little vasculature so that it can take it off and it will hopefully not bleed. So there we go. So the abdominal wall is cleared and we are ready to start. So I'm going to ask the anesthesiologist to please put the bed into what we call steep reverse Trendelenburg position.
Wow, that is a
which
$5
means
word.
That the patient, it is.
Yeah.
So that means that the patient is now, basically we're standing them up, right? You see the bed moving. So,
Oh, yeah.
we have a footboard on, so they go sitting up and down.
Whoa. What's that for? Why are we doing that?
So we do that because I need the visualization. The stomach it sits under the left rib cage,
Okay.
and I want that stomach to fall down more into the abdomen, and so it happens when you stand up. So that's why we stand them up. So the patient's pretty much not completely upright, but they're pretty darn upright.
Yeah, they're
okay. So let me show you the bearings here. I just kind of got into it. All right, let me back up here. So first, everyone, I'd like to introduce you to my friend, the stomach.
Yes.
This is the stomach right here. This is the liver. This is a healthy liver. They must have had a pelvic inflammatory condition at one point, which is why there's these adhesive bands here.
Okay.
I'm going to leave them in place because it's going to help us.
Oh.
The yellow here, that is fat that I have to take off of the greater curvature, this is the greater curvature, the bigger curve of the stomach. So we're going to go up and around here and take those attachments down. So I'm trying to get into a free space. You'll see it open up. There it is.
Yeah.
I'm trying to get into that free space behind the stomach. So we're taking all this down.
Okay. So she's going along the curve of the stomach, and she's going to take all that fat, all the connecting tissue off of it, so that when she takes the 80%, cuts that off, then it's not attached to anything.
Yeah, just the stomach.
Yes.
Is left. Yeah.
Exactly. So what a sleeve is called, it's called a sleeve gastrectomy. So gastric is another word for the stomach. Gastrectomy, ectomy means you're removing something. So in this case, with the sleeve, I'm going to take the stomach from the size of a football, and I'm going to take it down by removing 80%. What is left will be about the size of a garden hose or a small banana.
Whoa.
There's about 20% that remains inside. Yeah, a lot of people are surprised to see, and we're going to also show you the part that's going to come out of the abdomen on the stomach that I remove, and we're going to blow it up, and we're going to be able to see how much that stomach can hold.
Yeah, and think about that, guys. She just said football size
To a garden hose.
That is so crazy.
And I want to point out, we've both had this surgery done.
Yeah.
Like, we are both post-op, at least I'm 2 years, Mel's 6 years, and we're still like, what? That's what our sleeve is? That's the size? Like,
nuts.
Yeah. Didn't even realize.
Exactly. Now, here comes another fun organ on our path.
Yeah.
Up ahead, right here, this other maroon organ, that is the spleen.
Yes.
That's the spleen.
It's interesting how many different colors are going on in there.
Yes.
Yeah, there's a lot of colors, a lot of different colors. Actually, another cool thing is we have to white balance the camera so that we put it up against something white, and then it balances to it so that the colors look as normal as possible.
Oh.
So we did a little bit of that beforehand.
Ah, you're what is it? Calibrating.
Mm-hmm.
It pretty much, yeah, exactly. Calibrating for the color. Exactly.
Very cool. So, and then you're very careful around the spleen and any other. Obviously, you're very careful, but you want to make sure that you're not disrupting the spleen, correct?
Yeah, it's not a forgiving type of a situation there. That would not be good.
Okay.
So right now, I'm just taking down these last few attachments. So I'm just carefully making sure I don't touch the spleen, burn the spleen, poke the spleen, mess with the spleen.
What happens?
Trust me, you don't want to do that.
Yeah, what happens if that happens?
You could, in an extreme case, it would bleed, and it takes a long time for it to stop.
Oh,
or even let go of what you have and lift up at 12 o'clock. Or you could, in a really horrible case, even need a splenectomy.
Oh,
okay.
Wow.
Whoa.
Okay.
So let's not touch it.
Yes.
Let's not touch it. So sometimes that's easier said than done.
I would imagine.
Right now the camera's foggy.
Yeah.
Okay.
Oh.
So
He's pushing it
clean the
up.
camera.
Gotta wipe it off.
So right now we're cleaning the camera. That's why we came out, and we're going to go back in because it was a little bit foggy.
Yeah.
So we're going to go in. It's a little bit out of focus. So we're going to focus the camera, and we're going to go in. We're going to go really close so that I can see precisely where I'm at. So you can see it's really tight quarters in here.
Wow.
I got to be very, very careful. So there we go. That was like the money thing. Whenever I see that, I'm like, I can be relieved.
Yes.
Yeah.
That I'm now farther from the spleen, because as you can see, the stomach here, really it's intimately close to the spleen.
Yeah.
So there's these vessels called short gastric vessels, that I have to very carefully make sure that I fully seal those off with this ultrasonic dissector. And so that's very, very important here when I'm doing this. And what I'm doing is just freeing this up so that we could easily take that 80% out.
Okay.
And let's pull back here.
It is so crazy seeing the liver
And
like that.
can you show me over here? I think this is, oh, there we go. I got it in. All right. Now let's look to make sure we got all the attachments. Here, this thing that looks like a bunch of Cheez-Its, that is the pancreas. That's the pancreas organ right there.
Wow, it's so interesting.
Yeah.
So interesting.
Well, the fact that they're all layered on top of each other, a lot of people don't realize like how close together your liver, your stomach, your pancreas, your spleen, like they're right there.
Well, and when you have fat in your stomach, it kind of pushes them together even more closely, correct?
So there's different types of fat. There's fat that's more in the periphery, so more in the subcutaneous tissues. That means you don't, like this person here doesn't have hardly any intra-abdominal fat.
Okay.
She has a very healthy distribution. Her weight, for a reference, her BMI is 48 kilograms per meter squared. And almost all of her weight is in her hips and her buttock area.
Oh, okay.
So she's more of a pear shape.
Yeah.
So she doesn't have much fat there, but her abdominal wall is a little thicker. But the inside, the dangerous fat, the visceral fat, is not much at all.
Oh, good.
Now, the opposite side of that, some people have very thin abdominal walls, but that means all their fat is that dangerous fat all on the inside. They have a much, much, much higher risk with that distribution to get things like diabetes, and also a lot of those other really dangerous conditions.
And why is it so dangerous, the visceral fat?
Because that's diabetes and that sort of thing leads to heart attack, has the central distribution to weight where it looks like you kind of have a gut, if you will. You get that picture?
Okay.
All right. Can you flip down the vicinity, please? That distribution leads to, it just coats the blood vessels, the organs, and it leads to essentially fatty liver, which can be a big deal. It can lead to heart attacks, strokes, heart disease, all that kind of stuff.
Wow.
So it really has to do with our distribution of how our weight is.
Okay.
Just stop pushing for a second. So this, my friends, we just introduced into the mouth and then into the esophagus and then ultimately down here into the stomach. This is a sizing tube. And once I get it in the place that I want, if you could put that on suction, please.
No.
And once it's on suction, we're going to be able to start to create the sleeve here.
Yeah, what we're seeing right now,
so
guys.
what we're doing.
Oh, go ahead. Dr. Dovec's going to do it.
Yeah, okay.
Let me hear what we're doing right now. How much you girls know? You
yes, do it, Mel.
Well, I was going to say, so they just put the sizing tube down their throat, and then it's going into their stomach, and they're going to the one side of it, and then they're just cutting off the other side, which is the 80%.
Yes, so that she's going to use the staple tool.
Yeah, the gator. That's what we
call it. The gator, yeah. We've named it, no big deal. And she's going to staple down down that 80% versus the 20%, and then we're going to pull the 80% out.
Yeah, exactly. So just to refresh everybody, everything you see on the screen left here where that tube is, you can kind of get the idea. There's the end of the tube. That tube is being used as a sizing tube. And so everything to screen left, it's the left of that stapler, aka gator, that is going to be the sleeve.
Whoa.
And everything to the right, that is going to be the part that is removed.
Yes. Look at that.
So here, this is the end of the stomach. It's called the antrum.
Okay.
Antrum, okay.
So here we go with that. And you guys can see these tiny little rows. There's 3 rows of staples. 1, 2, 3.
Yes.
They're made of titanium, which is incredibly biocompatible. So that means that you can safely go through a metal detector. You can safely stand in front of a microwave. You could get in an MRI machine. And those staples won't do any harm So you can do that. There's no risk of having these inside of you. And as you can see, they're very, very small because this image is very magnified.
Yeah, definitely.
Yeah, I would describe it as like a seam in a shirt.
Yep.
When you like flip it inside out.
Yeah.
It looks great.
You got it. I think that's a good description of it. And you just want to make sure that seam, in this case, is airtight, that there's no bleeding, there's no leaking, there's no issue. You really want to try to stay perfectly on here. So
and what
now
size?
everything to the left is the sleeve. And then here, as we march up, you're going to start to see all the part that's going to come out, that 80% that's going to come out. Each time we go up, it'll make more sense as we go up the stomach here.
Yeah, and what size is this sizing tube?
The sizing tube, yeah. So there's different sizes of sizing tubes. So this sizing tube is a 36 French. I use 36 French on my sleeve, on my gastric bypasses. When I'm making this tiny little thumb-sized pouch, I use a 32 French.
Okay.
But every surgeon uses a different size there.
Okay.
What makes you want to do the 36?
I've probably done around 4,000 surgeries, and I feel that it is the Goldilocks size for me. I feel that 36 is the perfect size where it's not too big, but it's also not too tight or too narrowed.
Okay.
So I want to see optimal weight loss, but I also want people to be able to eat and drink and not have too much issues with nausea or restriction, inability to get it all in. So I think that there is a sweet spot here as well.
Love it. Love it. Okay.
I'm just so fascinated.
It's just crazy because, yeah, she's done
I know.
two sections. Now we're going for the third.
Yep. And do you always have to
Yep,
do
so this
3 sets of the staples?
So so it'll end up being the amount of, these are called loads. So the amount of firings of these loads that I'm going to take is almost always about around 5, I'd say on average,
Okay.
5 or so.
Okay.
5 or so.
So
And you
this
said,
is a good shot here to show sleeve and remove portion.
oh, that is a great shot because that's where I get the whole, like, it looks like a gator because it's just like
Yep.
taking a chunk out of it.
Harr, harr. Is
Yes.
that how gators sound? I don't know.
I have no,
I
It's
would
like a
say
dog
yes.
and having problems.
Well, I've seen gators, and I would say yes.
you would say yes.
Yes.
So you said her BMI was 48. Now,
Yes.
what was the reasoning for the sleeve over the bypass?
So I do allow patients to always decide which operation they prefer.
Okay.
I do help to guide patients, but ultimately it is their decision. They do, I hope, a lot of their own research and that sort of thing. So the 3 things I tell people to consider when picking an operation, number 1 is BMI. The results are a little bit better statistically with the gastric bypass. So if their BMI is over 45, I do urge them to go with the bypass. If they have acid reflux at baseline, I also tell them to go with the gastric bypass. And then finally, if they are a diabetic, I tell them to go with the bypass. So she does not have reflux. She is not a diabetic, but her BMI is on that border. But I think, listen, everybody does differently with it. You girls have obviously excelled with your sleeves.
Yeah.
It just takes, it takes a lot of hard work and grit to just really stay on topic and just make sure that you are, you're compliant with all the recommendations, the fluid, the protein, the minimizing of the snacking, the vitamins. You guys are helping to preach it every day to keep people accountable. I think it's super important.
Yes. I mean, we just talked about it in our intro about how this is a tool and you have to be able to use the tool in the way that it is directed. You can't just expect it to do all the work.
Yep.
Exactly. This is a tool. I'm using tools to create a tool.
Yes.
But it's, I think that's so true. And you have to always keep that in mind when you're doing this. So here comes another load coming off there.
Wow.
It's looking really, really, really pretty. We
Yes,
are
it
happy,
is.
Here on our side. So so what you see my assistant continuously doing is making sure that all that little extra stomach pouching underneath there, we're making sure that we're sweeping that out, like as if you're taking your hair and sweeping it off of your shoulder or out of if it's stuck in your shirt, sweeping it out so that it remains so that there's not so it's sort of like this sweeping motion like this.
Mm-hmm.
So just to make sure that it remains as tight as possible, and there's not an extra storage up there unnecessarily.
Got it. Okay.
Yeah.
And each time you pull the gator out, you have to reload
Yes.
it.
Yes. So it's only a one-time use.
Okay.
Every time it fires, we then have to reload it. And believe it or not, there's different colors that are used at each time I'm firing. So when the tissue is thicker, we use, for example, the color is green.
Okay.
And that's because the staples have a higher height. So I want the higher height to go through the thicker tissue. And then as I come up around the bend, as you get closer up here to the diaphragm,
mm-hmm.
that's where it becomes a little bit thinner. So here I'm using golds, and then I might even switch to a white. So that each of these colors mean something. We know what they mean. We know what the staple heights are that are associated with it.
Okay.
But we do adjust it as we go around and up towards the end here.
Wow.
I love it.
What were you going to say?
Now, I want to show you guys something.
I don't remember.
I want to show you guys the diaphragm, and
Okay.
I want to show you a little important organ that you're going to be able to see through. Let me see. Yeah, let's take another whiff, and then I might need a white. Yeah, gold whiff. All right, so, okay, we're going to pull back with the camera, and I'm going to show you guys, this is the diaphragm muscle.
Okay.
And do you see that thing beating right there?
Oh my God.
That's the heart.
Man, that is insane and intense to see someone's heartbeat like that. Like,
Wow.
Exactly. This is a real live human being right here, and their heart is beating, and the anesthesiologist is, of course, monitoring all of the vital signs, the oxygen saturation. So that always during these procedures, you'll have an anesthesia provider who is one-on-one to you, the patient, who's constantly looking at your blood pressure, looking at your heart rate, looking at your oxygen saturation, looking at waves and patterns of the rhythm strip. So there's a lot of constant just staring at your performance.
Yes.
I like
the
it.
anesthesiologist is laughing, but there's a lot of staring, and actually it's kind of funny. I was going to say a lot of listening. So there are some different beeps that are going on right now. And so there's a certain pitch of the beep that I'm like, all is copacetic. We are all happy. But there's other deeper beeps that we're all like, is everything okay? And we can be talking, but you're just so trained to know the sound of the beep.
That's
exactly.
amazing.
Exactly. A regular beep. I hear the patient's heart rate beeping in here, and you don't even know it. And then I will take one more white after this. All right, sorry. Sometimes the camera gets blurry, and then we have to fix it.
Yeah.
I wish we could just edit that out for good.
Yeah. I love how thorough you guys are, because
Yes.
like watching this, like they're tilting everything. They're looking under, over, sides. Like they're making sure this is like very clean and precise, and that this is done like correctly, and that way you guys have like really nice surgeries without pain and stuff. So.
And you can tell that you guys are like, you're on point. You know what you're doing. You're trained to do this well, and you use that to your benefit and to the patient's benefit.
Yeah.
Thank you so much. Yeah, we do a lot of these. We're a highly efficient team. This is our fifth case today. It's 12:48 p.m. and it's because 12:48 Eastern, and it's just an incredibly talented group of individuals who we are all singularly focused on making sure that the patient has a fantastic outcome.
Yes.
We
Yes.
try everything humanly possible, and like you guys say, we're going to measure a billion times, and then we cut once. We only got one chance to make this perfect at each of these times that I'm cutting here.
I bet.
Yes.
And this is going to be the last one, you guys. This is the last one.
And then it'll be our
after
favorite part.
Our favorite part is coming. Here we
Yeah.
go. So, all right, guys, here we go. I would like to say congratulations to this patient, because they are a proud owner of a new sleeve, everyone.
Yes.
There it is. They have a sleeve.
Welcome to the
Awesome.
winner's
So we're gonna-
bench.
Yeah, the winners.
Yes, winning by losing, my friend. So here's the
Yes.
sleeve, and actually we're gonna have that sizing tube completely removed. here's the gallbladder. The gallbladder's job is to store bile. Bile is sitting inside of that, and then it just goes into the first part of the small intestine, and that's called the duodenum. And here is, the tube is out. Oh, that's so pretty.
Yes.
Mommy likey. We're going to take a picture of the liver on that side and the entire liver. And then we're just going to slowly go up this staple line here. We're looking for any bleeding, anything abnormal. And if we see bleeding, we'll clip it, but that is perfect.
Yeah, it
Perfect.
looks
So
great.
spleen, pancreas, sleeve, stomach, pylorus, duodenum or small intestine, gallbladder, liver with some perihepatic adhesion.
What's that?
Yeah, can we talk a
later?
more?
I have a feeling you guys could ace it. All right, guys, what we're going to do, yes, let's get this image. We're going to pull out, by the way, Kelly, guess what? This right here, this instrument right here that I'm showing,
Yeah.
this is a Kelly clamp. It's named
Oh my
after you.
gosh. I feel so honored.
You should. A Kelly clamp for Kelly watching. All right, guys. So we're going to show a split screen here, and we're going to show an image inside the abdomen where I'm pulling out the stomach, and an image outside of the abdomen where, okay, are you ready, guys? We're going to go nice and slow.
Oh, my God.
Here, I'm going to wait for Nick to get in there.
There we go.
And here we go. So do you guys see it coming
Oh
out?
my gosh.
It
Oh
just
my gosh.
slowly coming
Okay, here
out.
it comes, guys.
You can see it on
Oh
both
my
ends.
gosh.
Oh, my
It
God.
is a beautiful, lovely.
Ooh.
Almost. There we go.
Baby.
Yes.
Oh, it's a sleeve. It's a sleeve.
It's so
Fantastic.
crazy.
Now, you see my finger?
Yeah.
Hi, guys.
Yeah.
My finger there. So what we're going to do is I'm going to tighten up this hole, and I'm using this a suture. It's called a chromic. It lasts about 5 days, and then it either absorbs or pops. And it's just a way of reapproximating the tissue together so that this will not form a hernia, because that could actually get herniated, or things such as small intestine or fat could get stuck in there, which could be very painful.
Okay.
So I'm going to close this out because this is the hole really close to the belly button where we really close to the belly button where we pull the stomach out. So here we go.
Okay.
So you see that's tight. So that area at this stitch can be very, very painful because it's I have to tighten muscle. It's a deep stitch. So that could be very tender in that area.
Okay.
All right, now I'm going to take the last bit of the numbing medicine here, like lidocaine that you might have for dental work, that sort of thing.
Okay.
And I'm going to, you can see the needle kind of coming through there, and I'm just going to take it and really just, there we go, numb that whole area up. And now I'm going to cut that off. And then we're going to take one more look inside the abdomen before we're going to deflate it, so you guys can check that out as well.
So
there it is. Beautiful sleeve.
Wow.
There's the spleen. There's the sleeve again. I don't see any bleeding, no issues. Perfect. All right, guys, we're going to deflate it. We're coming out so that we're letting all the gas out. You might hear the hissing of the gas.
Oh my
And
God.
I am going to clean that whole area out and dry it off.
Look at that.
So
It
this
just goes down.
patient is a proud owner of a sleeve.
Yes.
This is amazing to see. Like the stomach deflated. They're pushing on it.
Wow.
Yeah, we want to try to get as much, we're really going to push on it here. We want to try to get as much gas out as possible. And then if you could level out the table and put it up a little bit. Now what we're going to do is we're going to close these incisions with a plastic surgery closure. So it's called subcuticular, where I'm going to approximate the tissue together. And I don't use any, there's not going to be any stitches or any staples that need to be removed. There's just going to be a thin layer of waterproof skin glue over these very cosmetic incisions.
Wow.
Awesome.
Love it. Love that you think about that, because once you lose all the weight, you want to show everything off. And some people don't like those scars. I mean, personally, I take them as battle wounds.
I do too. I don't give two shits about scars. Like this is my body, man. This is what's happened to it.
This is what it is.
Tells a story. Like no one's perfect. There's no way.
Yeah.
No freaking
No,
way.
I agree. I do. So no matter what you say, oh, I don't care, I won't care. I can't help it. I'm super neurotic about making this super sleek. Now, I don't know if you guys overheard, but just now, the team in the room was counting the instruments, and they just want to make sure that all the sutures, all the stapler loads, everything that was there at the beginning of the case is there at the end of the case.
Okay.
We want to make sure that there's nothing left inside and everything, the counts were correct. Everything tallied out as it was supposed to. So that's an important part of quality assurance in these procedures.
I like it. Because I have heard horror stories of like stuff being left in there. So I'm glad you all are counting.
Yes.
Oh yeah. Everybody has a story. This patient's skin is amazingly coming together.
Yeah.
Typically there's certain, especially African-American skin that, comes together like it's almost like the scars disappear before your eyes.
Wow.
He has that type of skin.
Love it.
So it looks so good. We'll have to show you how that looks.
Yes.
But we are also on the back table, we are starting to blow up our sleeve specimen. So we're going to show you a little bit about how much that sleeve stomach can hold here.
Yes.
So crazy.
It's we're having some fun here on this one. It's looking
wow, that looks incredible.
like it's really distending up over there.
Well, and your stitch work, like that's already going away.
Yeah, that's what I'm thinking. Like I meant that's incredible that your stitch work.
Yeah, like that's nuts. See, we want you to be neurotic about it.
Do you see this? Look how good that.
Like
Yeah,
that
hold on,
just
let me move this
disappears.
thing. And can you lean back for a second? Here, look at this.
Yeah.
Look how good that incision looks.
Wow.
It's
See, it's
seriously.
gonna hide in our belly button.
Yeah.
Button, and this stitch isn't even closed yet. And then this one is. I have blood on it. Here we go. There we go.
That's so nuts.
Wow.
It looks just like a little tiny cat scratch or something.
Yep.
Like you would never guess a
little
stomach
tiny
came out of
cat
there.
scratch?
Yeah.
Oh my gosh.
Oh my gosh, you guys are wild. I love it.
We try to be.
We got gators and we got cat scratches.
Yeah.
Well, that's a new perspective. I've never thought of it like that.
That's what we're here for.
That's right.
Give you the non
technical term.
Yes, there you go. Oh my gosh.
I need what the public thinks, and if I hope that this will show someone that wow, of course it's a major operation, of course there are risks. However, I hope that you guys see that it's a lot calmer than you think. It's very efficient, and the results. Well, you two ladies show that the results speak for themselves. I mean, it's pretty cool stuff here.
Yes. I mean, there's so many people in the bariatric community that has just kicked ass at their journeys.
Yeah.
And they work so hard day in and day out to make this new life worth it.
Yeah, we're so proud of them, and just knowing that like this was 20 minutes, 25 minutes.
Yeah.
Like, guys, if you want your life back, all it really does take is that 25 minutes in that operating room, and then you're set for life to start your journey, and then the hard work starts, and you got this. So don't be scared of the surgery.
Well, the surgery, I think everybody kind of says like, "Oh, it's so scary. It's so scary." It's really not.
It's really not.
Like, it's a very safe surgery for the most part.
Well, absolutely. And, I think, Mel, to your point, the 25 minutes is the easiest 25 minutes of the journey.
Yeah.
Correct.
Because you're snoozing. It is a lot of hard work, and both before surgery, setting expectations, getting educated, getting prepared, having everything ready for yourself. And then ultimately, the fun happens after the surgery too. You'll see some results, but it takes a lot. All right, I'm going to go over here to this side to the back table. This one's going to be a big dog. This is good.
Ooh, look at it get big.
Look how much of this is coming out. That's crazy, huh?
Yeah. This is nuts.
Yeah, because if you look at it in reference to their hand.
Yeah, look at that.
Yes, exactly. Here's my hand, and I'm tall.
Yeah.
And look, it just extends way over
you need
there.
2 hands.
Two hands. And it's like,
yes, it's like
that is crazy how big that stomach is.
So that's normally what it would look like with food
we
and
have a lot
water
of
in it,
room to
right?
go. So what she's putting in there is CO2 gas.
Okay.
So that's blowing it up and helping to distend it. And this shows you why sometimes you feel like I am so bloated and full. This is why your stomach could have a lot of air and gas retained, and things can just sit there. It can be really uncomfortable, as you can see.
Yeah.
So this one is. There's still a ways to go. We're still going.
That's crazy.
Oh my goodness.
So when this person comes out of, oh, sorry.
Oh yeah, go tell us.
Yeah, when this person comes out of surgery, like how fast are you wanting them to move around and walk around and do all those things?
I want them to move around within 15 minutes of coming out.
Wow. Whoa.
And our patients do.
That's awesome.
And how often do you want them to move?
All right, we're going to go to this camera.
Okay.
All right, so we're going to zoom back.
We're going to take a look at the stomach.
All right, guys, are you guys ready for it?
We are ready.
Let's see
All right, can you look up, please?
Okay, I can't see it yet.
Okay, where do you need me to stand? Hold on. Let me get out of the way. Here, it's because you see the camera is like being blocked by.
Yeah, some arm of something.
Yep.
Yeah.
Yep, we're getting there.
There's an arm. Okay, we're getting there.
Almost.
And then if you could.
Maybe full.
Yeah, there we go.
Okay, here we go.
Wow.
Okay.
Look at that.
Oh, and he's going full screen. Let's
Yeah.
There it is.
Yeah,
There it is.
there we go.
Now,
Perfect.
Here, if we can, I'll try to stay still. If we can show the definition of these staple lines. Actually, let me turn it around this way.
Oh my God.
And so that I'm going to stand still. Do you see these little tiny 3 rows of staple lines?
Yes.
Yeah.
Oh.
Yeah, so that just shows you that there's 1, 2, 3 rows that come out with this specimen, and there's 1, 2, 3 rows that stay in on the patient. Wow. So it shows you how tiny they are, and these are the things that are made of the titanium that I was telling you about.
Yeah.
Also, this part of the stomach that's removed, mainly the fundus, it's also responsible for making a hunger hormone called ghrelin.
Oh.
So ghrelin is that thing that tells your brain, that signals to the brain to eat more. So since this is removed, for appetite, especially immediately after surgery, is going to be greatly reduced. So it's so important that patients continue to eat 3 meals a day, even if they're not hungry, to make sure that they get in all of their protein and all of the fluids too.
Yes,
Okay.
Fluids, guys.
Fluids, and protein.
Get those vitamins in, man, because
You
like
got it.
that looks like a little baby.
It does look like a little baby.
Like you could like coddle it. See, yeah, it's so nuts.
I love it. Oh my gosh, it's so.
Well,
So my question for you is, we've had a couple followers that had contacted us and said, like, I'm not feeling restriction, or I am still hungry all the time. Is that a possibility after?
Or is that a mental thing?
absolutely. If you feel hunger, it's probably real. You might not have eaten enough protein at the meal before.
Okay.
So if you do that, hopefully you have some good protein snacks, and I'm sure we can do some great podcast information on what those could be.
Definitely.
That's very important. And it's also important that you're eating enough at a meal so you're not snacking or picking too much in between meals.
Okay.
But you can see the stomach's really small. It doesn't stretch back out. It doesn't grow back. You saw all that came out. That's not going to go back in there. So that's all super important.
Great.
I love it.
Now, my ladies, thank you so much. We're turning over the room now. We're preparing for the next cases.
Awesome.
Kellie, Mel, our Sleep Life podcast, I'm going to sign off. I'll let you guys chat, but thank you for the opportunity to let you back behind the doors of the OR.
Yes, thank you.
We love you guys.
Yes.
You guys are amazing.
Yes, we appreciate you. Oh, there we go. We're done. Okay.
Well, that was
All right,
intense.
I'm logging off. I'll talk to you guys later. Thank you.
Okay.
you.
Bye.
There you guys have it. We got
Hold
to.
Let me leave the meeting.
Oh, there we go. Yeah, there you guys
There we
have
go.
it.
Okay.
That's insane. That's literally, I think it took 20, 25 minutes, maybe half hour, and it's done. And they get to start their journey.
This patient just gets a whole new life.
Yeah, a whole new life. Like, and when you watched her do that, like, she was so quick and, like, very precise. Like,
well, and she said, like, measure 3 times, cut once.
yeah.
And I love that she takes that saying to heart.
Seriously. And I know because my husband is a person that like builds stuff. That's so important.
Yeah,
So
because
important.
I'm the type person to cut first and then measure.
You're like, oh, wait. I forgot to measure that.
Oh, crap. Just kidding. Let's start again.
Let's
And you
start
cannot do that in these surgeries. So
No.
we are so thankful for Dr. Dovec for taking the time and her experience to make sure that every patient has the best experience possible
the best care, man.
and gets to just start their life and not have to worry about this part.
It's so important. And she is wonderful and a blessing that she's like willing to let us go behind the scenes and really see it.
Yes.
Because I had no idea that's what was really happening inside my body.
No, I had no idea.
There's no freaking way that was happening. The fact of all the layers of your organs and how they really are compacted on that one, like your left side. No clue.
Yep.
Like I got, you see the like anatomy stuff like in school, but you don't realize like how on top of everything it is.
Yes. I mean, this whole experience was just incredible. And I know me and Mel want to thank Dr. Dovec, her whole team, and everybody who helped put this together, because this is just an incredible experience for us.
Yeah, I'm still in shock, and we got to see so many surgeries today. So
yeah,
we appreciate you guys.
We do, and we appreciate all of our followers for listening, and hopefully this helps somebody out there make a decision to get weight loss surgery and start their life.
Yeah, don't be scared.
Don't be scared.
Don't be scared.
And if you are, talk to us.
Yeah, call us, message us, do your thing. Like we want to help you not be scared. That is the whole point.
Yep.
We don't want you to be scared or alone. You have us. You have Dr. Dovec. Like we will take care of you. Watch these things because it will really be an eye-opening for you. You get to really choose which one will be better.
Yes.
Which one did you
And
like?
they're really not. Like, I just expected, like, all this blood, right?
I know.
And it's just not like that.
No,
And
like,
it's so crazy.
I think what I've learned from watching these is that literally, like, the blood's just in the organs. And so, like, when you open up, there's not just blood everywhere.
No.
It's like, if you touch an organ wrong, then the blood
Then
comes
there will
out.
be. I mean, we didn't see that.
No, and that's why
But-
she said, like, we're going to check for blood. Is anything leaking? And that's really what they're worried about. So, I mean, it's impressive.
I mean, this whole experience is impressive.
Seriously.
So, yes. All right. Thank you guys so much for listening, and we will see you guys next time. Bye.